Good afternoon. My name is Dr. John Rice, and I'm a transplant hepatologist at the University of Colorado, an assistant professor. While my clinical interests include acute chronic liver failure, management of portal hypertension, and alcohol-related liver disease, I treat all forms of liver disease. And more importantly, one of the best parts of my job is educating my patients on their health. It's my pleasure to welcome you to the American Liver Foundation's Ask the Expert program on primary sclerosing cholangitis, or PSC as we'll call it going forward. It's a rare disease that slowly damages the bile ducts and can lead to serious complications. Primary sclerosing cholangitis affects approximately 20,000 Americans. Today, we'll be learning more about what causes PSC, how it's diagnosed, and what are the complications of PSC. Before this program, we asked what questions you have about PSC, and today I'll be answering those questions. If you have any additional questions, please post them in the chat. I'd like now to introduce today's speaker, Dr. Kenneth O'Riordan. Dr. O'Riordan is a leading gastroenterologist who for over 30 years is dedicated to helping patients with his caring and understanding approach. In his clinical practice at Lakeshore Gastroenterology and Liver Disease Institute, he provides comprehensive care for patients with various gastrointestinal, liver, biliary, and pancreatic disease. He is board certified in internal medicine, gastroenterology, hepatology, and liver transplantation. Thank you for joining the program, Dr. O'Riordan, and we appreciate your time. I think let's get into the first questions. First one off is going to be, what is the cause of PSC?
Well, thank you very much for inviting me to participate. I'm glad you started off with a nice, straightforward question. I'm not sure I quite have the answer to this, but certainly there's probably a combination of things that probably relate to the pathogenesis of PSC. There's obviously a strong association with a lot of patients with inflammatory bowel disease. There may be some underlying immunological abnormalities in some patients, although we don't really have a specific genetic marker to detect these. And then probably, some genetic components to these, and some of it does occur in families. So I think there's a lot of different things that could cause the pathogenesis of PSC without being one particular underlying factor that relates to it. But certainly I think the association with inflammatory bowel disease is probably the single most helpful thing in diagnosing this or understanding the pathogenesis of this.
Excellent. So next question going to be is, are there any symptoms of PSC?
Well, there's certainly two different groups of patients. Obviously, patients who are symptomatic, with PSC, who may present with typical liver test abnormalities found by their primary care doctors. Sometimes abnormalities are found on imaging, or they may develop some complications of PSC, such as jaundice, pruritus, abdominal pain, weight loss. So there are varied symptoms. A lot of times this is picked up just routinely on blood biochemistries or imaging done on the abdomen for some other reason. So not every patient who has PSC is symptomatic, but certainly as the disease progresses, the frequency of symptoms definitely does increase. I think in the old days, we would see patients much more commonly because of symptoms of PSC. Nowadays, I think we're seeing it a little bit earlier in the disease course, than we used 2 years ago.
Interesting. And you kind of alluded to this, but can you explain the progression of PSC and how that occurs?
I think overall in PSC, there's generally a slow progression, of the disease. I mean, if there's a rapid progression of disease, you're always concerned about progressive complications of cirrhosis, certainly about the development of cholangiocarcinoma or bile duct cancer. In most patients, it's usually a slowly progressive disease over probably 7 to 15 years, and it's variable in patients. Some patients have a stable disease for many years and then rapidly deteriorate, and some patients have sort of a gradual deterioration over many years. So there are different predictive models that we can look at based on various different parameters that try to predict progression of PSC, but I don't think any one parameter is indicative of progression in the individual patient. I think those models are very helpful when we look at large groups of patients with PSC.
So yeah, it seems that it's difficult to predict who's going to progress and at what speed right now. One of the other questions that people had was, how is PSC diagnosed, and is a biopsy necessary to diagnose PSC?
I think there's a couple of different questions in that. One is, how is PSC diagnosed? I mean, up to 10 to 15 years ago, we would always diagnose PSC typically by doing an ERCP or a dye study of the bile ducts to look for characteristic features such as strictures or beading of the bile ducts, either in the extrahepatic bile ducts or the intrahepatic bile ducts. Now, with the advent of non-invasive testing such as MRCP, a lot of times we're picking up patients with PSC based on abnormal imaging and try not to do invasive testing such as ERCP on these patients unless there's a concern about malignancy and tissue sampling that's needed. I think the second part of your question is, is a liver biopsy required? I don't think a liver biopsy is required to diagnose PSC. In the old days, we would always do a liver biopsy to diagnose PSC to stage the disease. But typically now, if there's characteristic findings on non-invasive testing and there's no secondary cause of bile duct damage, such as stones or instrumentation of the bile duct, then I think you can reasonably confident about making the diagnosis. Certainly biopsy may help in some patients. There are some patients that just have intrahepatic or small duct PSC, and I think those patients, probably do benefit, from getting a liver biopsy. And then I think liver biopsy does help stage the disease, although sometimes the findings are very non-specific, so it's not always very accurate in the diagnosis of PSC, but certainly I think it does add to a lot of these patients with PSC, but not required, I think, in every patient.
And in addition to the imaging findings and biopsy, is there any blood markers that you ever send off for PSC?
Yes, I think it's important to exclude other causes of chronic liver disease, but autoimmune markers. We typically will send off anti-mitochondrial antibody tests to exclude any PBC or primary biliary cholangitis. Typically, we'll send off immunoglobulin 4 markers to look for any overlap syndromes, and typically also send off anti-nuclear antibodies, anti-smooth muscle antibodies, just to screen people for other causes of chronic liver disease. Sometimes these blood tests are helpful. Sometimes we'll send off a P-ANCA as well in these patients. So I think it depends on just the clinical situation. I think we typically run all these blood tests on people just so we can better characterize the PSC. Is it absolutely necessary for the diagnosis? Probably not absolutely necessary, but I think it is helpful to exclude other causes.
Perfect, thank you. And so the next question that was asked was, is it possible to inherit PSC from your parents?
Well, definitely there is a genetic, predisposition to PSC. So certainly there's a small percentage of patients, probably maybe 5% of patients who can develop PSC. Whether all those people will be symptomatic or not is sort of debatable, but certainly I think there is definitely a genetic predisposition. Do we routinely screen all children? In our practice, we don't routinely screen everybody unless they start to develop liver test abnormalities or something else that's of concern. So I'm not sure what you do in your practice or whether you routinely screen everybody in your practice.
So, I mean, as far as when someone's coming in, I definitely ask about their family history if there's a diagnosis in doubt, because obviously the presence of it in the family, as you said, can increase your concern in a patient. But there's definitely no obviously genetic markers or anything that we would also do for these patients. Unfortunately, just have to make their children aware of the diagnosis. So if something happens, that they know that it's in the family. Perfect. And the next question was, is my immune system compromised if I have PSC?
Well, I think if you look at all patients who have chronic liver disease, you could argue that, yes, their immune system is compromised, because they have an underlying condition. They may be compromised because of the underlying condition or because of complications of the condition, or sometimes it's compromised because of medications that are used to treat the patients. So I would say that, yeah, we would definitely recommend these patients obviously be careful with all their other medical illnesses, make sure their medical health is up to date, make sure they get appropriate vaccinations, for hepatitis as well as flu and pneumovax, all those types of, vaccinations. So I think, yes, the immune system is definitely compromised. A little bit different to patients, I think, who have underlying carcinoma, but certainly all people, I think, with chronic liver disease definitely have a compromised immune system.
Yeah, definitely if they've developed the cirrhosis as well and can have ongoing immune dysfunction as well in those patients. So good. The next question is going to be, what foods should I eat now that I know that I have PSC?
So I don't think there's really a specific dietary requirement, for people with PSC. I think depending on the stage of their liver disease, we generally recommend people to be on sort of a low-fat, low-salt diet. I mean, there's a lot of controversy about how much protein people should intake, whether they have hepatic encephalopathy or confusion associated with chronic liver disease. But I typically tell people just to, probably avoid drinking alcohol, avoid excessive amounts of Tylenol, and then really just eat a healthy, balanced diet and make sure they take in adequate amounts of fat-soluble vitamins if they have cirrhosis or if they're jaundiced or if they have itching, to make sure they supplement those. But otherwise, we recommend just, a normal, healthy, nutritionist, non-American diet.
Yeah, it's unfortunately, the American diet has become unhealthy for a lot of health problems, including what we're talking about today. And can you explain a little bit the fat-soluble vitamins a little bit more for people, why those are important in PSC?
Yes, I think, until the people develop complications of PSC with jaundice or bile duct obstruction, pruritus, probably there's not a huge problem with fat-soluble vitamins, but certainly when they develop progression of their liver disease, people typically have problems with absorption of fat-soluble vitamins such as vitamin A, vitamin D, vitamin E, and vitamin K. And those can present with either complications or just with lab test abnormalities. So there are, oral formulations that patients can take to supplement those vitamin levels. You can empirically just treat people with those vitamins, or you can go and measure those, serum vitamin levels depending on the progression of their liver disease. But I think it's unusual to get significant depletion in those vitamins when people have normal liver tests and when they don't have jaundice and when they don't have itching.
That makes sense. Yeah, it's something obviously that hopefully the providers are checking for and keep an eye on things as well as their disease progresses. All right. So another question that was asked was, with someone with PSC, is it okay to start a family? And is there any precautions that they should make?
Well, I think a lot of these patients, are diagnosed at young ages. So they're typically not being diagnosed at 60 or 70 years of age. So obviously a lot of them are of childbearing age. I think there's definitely increased risks of patients going through fertility and having a family when they have complications of cirrhosis. So those are definitely a different group of patients. I think patients who are relatively early stage PSC, I think it's very safe for them to go ahead and have a family. It's probably the safer time to do it before they develop complications. I think once patients develop complications of PSC, such as cirrhosis with portal hypertension, then I think the risks for going through pregnancy are obviously much greater. I think for men with PSC, I don't really think there's any significant, increased issues going through and starting a family. For women, I think it just depends on the stage of their liver disease. So it is helpful to know the stage of the liver disease and the complications that are present before thinking about starting a family.
Makes sense. You alluded to this before when you were discussing the checking other types of liver disease when evaluating for PSC, but someone asked, is there a relationship between PSC and PBC, and can I develop both?
I mean, there certainly are some patients, it's a very small percentage of patients, who can develop, a combination of both diseases. So I think it's important to exclude or figure out which is the most prominent disease. I mean, typically with the PBC, the bile ducts are typically or normal on MRCP. I think people with PSC, the characteristic feature is the abnormality in the bile ducts, but there are some patients who have PSC who have positive anti-mitochondrial antibodies. That's not a high percentage of patients, but certainly we do check to make sure, which is the more prominent disease. And sometimes liver biopsy may help in those patients, like it helps differentiating other types of overlap syndromes that we see with autoimmune liver disease and PBC. So, but certainly the incidence of PBC and PSC, I think, is much lower. So overall, that risk, I think, is low.
Yeah, definitely something that should be screened for, along with, like you said, overlap for autoimmune hepatitis, which, it can occur and can look different on labs and requires attention if someone's PSC is not acting typical, should be further investigated with the biopsy, because not all PSC patients get biopsies, like you said before. And so keeping that question in our minds as we watch patients progress is important.
Yeah, I think the important thing is just to see if the patients are progressing sort of in a typical fashion. If something looks abnormal, like the liver enzymes are very high, or they don't have typical radiographic findings of PSC, should make you always look for something else that could be causing the liver test to be elevated.
So next question is going to be, what is the association between PSC and inflammatory bowel disease?
Well, if you look at a lot of patients with PSC, not everyone with PSC has inflammatory bowel disease, but there's a high percentage of patients who develop inflammatory bowel disease, either ulcerative colitis or Crohn's disease in association with their PSC. The timing of this is variable. So a lot of patients may develop it at the same time. A lot of patients may develop it subsequent to the diagnosis of PSC. Most patients probably develop the inflammatory bowel disease prior to the development of PSC. So I think if you have a patient who you have initial diagnosis of PSC and they've no bowel symptoms, these people should undergo some type of colonoscopic screening and evaluation to see if there's inflammatory bowel disease. A lot of the patients already have symptoms of inflammatory bowel disease, and often the PSC is diagnosed after the diagnosis of inflammatory bowel disease is made. So patients with inflammatory bowel disease are found a lot of times to have elevated liver tests for multiple different reasons, one of which is PSC. So I would say most of the time it's more the inflammatory bowel disease we see first, followed by the PSC rather than the other way around. But obviously it can happen the other way around, but less frequently.
And the combination between the two, is it felt to be the same process or one driving the other, or what's the common theory behind that?
Well, there's a lot of controversy whether one leads to the other or not. I mean, a lot of patients, if they believe a theory of some translocation of bacteria and whether that's related to the development of PSC or vice versa, but probably more likely it's probably related something to do with bacterial translocation and some genetic predisposition, that probably a combination of those two things may lead to the development, of maybe a susceptible patient. So not everyone who has, IBD is going to develop PSC, and why do a lot of patients not develop PSC? So we don't really have a good way of predicting when you have inflammatory bowel disease, which patients will develop PSC. And it's also interesting why a lot of patients with PSC don't have inflammatory bowel disease, although that's usually a small percentage of patients.
So next question is going to be, what causes the itching and what treatments are available for itching?
Well, I think there's a lot of controversy as to what causes, itching. Whether in the old days, we would always think this is related to sort of bile salts in the skin, although there's not really any correlation probably with measurement of bile salts and the degree of itching or measurements of itching. Whether something is related to some abnormal receptors in the skin that may be the trigger for people's itching, it's possible that could be related to it, whether it may be a central cause for the itching. But I don't think there's one definite theory as to the only cause for itching in these patients. And I think that's what makes the treatment of itching extremely difficult. I think typically we've used, bile acid sequestering agents such as cholestyramine or Questran. Sometimes you give symptomatic relief just with lotions, sort of olive oil, those type of things, which are symptomatically helpful for some patients. In the old days, we used to use a lot of rifampin for treatment of itching. Now we probably use that much more for just resistant cases of itching. We've used a lot of Zofran for itching, which we actually find very helpful, even though it's not licensed for itching. And then newer drugs such as naltrexone, we've used in some patients, but some people can get some significant sort of side effects from naltrexone. And then Actigol or Urso, we've used for some patients with itching. I think it's a little bit different in the PBC patients with itching. It may improve a little bit. I think the PSC, a lot of times when the itching gets severe, a lot of times it's related to anatomic issues. I'm not sure the drug treatment is as helpful for itching in PSC as it may be in PBC. As in other medications, we really don't have good data with other medications, in treating PSC. I mean, there's been trials on various different medications over the years, and really none has shown very good efficacy in PSC, unfortunately. So I'm not sure what your experience is with treating patients with PSC. We've sort of initially treated people with low dose Urso, and we've sort of left patients on it who have been on it for years in the hope that maybe it helps. We certainly have shied away from using high dose Ursodiol, but as for other treatments, we really have not been using any particular medications for PSC at this time. So I'm not sure whether you or your university are involved in any new sort of trials looking at different medications? So certainly an opportunity for medications, but I think there's not good data.
Yeah, at this time, unfortunately, yeah, no medications that are been proven to. We will start ursodiol in patients who have a history of strictures or stones, or have another indication for have had sludge issues, cholangitis, things like that, or patients who are already on it. Commonly, we will leave them on it and not stop due to the kind of the changes in enzymes that you discussed earlier. I know that there's some ongoing trials at like moderate dose ursodiol instead of high or low in seen, and I know that data is not fully available yet. And I know that commonly you'll see in a lot of the discussions, and patients bring this up, is vancomycin. I know that there's ongoing research into that, and there were some early studies in the peds population that were very small and haven't always borne out in the adult populations. What's your stance on vancomycin when a patient comes in on that, and how do you approach that question without the lack of complete data?
I mean, we talked to them about it. I think in the absence of good controlled data, we sort of try and shy away from it because we may need it for other indications down the road, especially in the transplant patients. So we sort of have shied away from it unless we end up seeing good data that it's really beneficial. I think it's something you can discuss with patients, but like you said, we just don't have good data, and you're always worried about antibiotic resistance in patients without good reason to use it in the first place. So I think you sort of have to be careful about using that in all patients. Maybe selectively some patients you can consider using it, but I think at the moment for general use, I think it probably is not recommended.
Yeah, unfortunately, it's and worrying about these patients who might also have ulcerative or inflammatory bowel disease and C. diff risk, and like you said, resistance is obviously a problem in these populations and with C. diff. So it's tough to tell a patient with this new diagnosis that we don't have any medications that are going to prevent it at this time. But hopefully, some of these clinical trials in the next couple of years can find some new tools for us to use in this patient population.
Yeah, I think it's definitely very frustrating for patients. They come in, they sort of think nowadays there's a drug that's available for every disease. Mm-hmm. And I think the issue with PSC, which I think is very different from PBC, is it seems to be more of a mechanical obstruction, in patients. And really, we don't have good ways of treating mechanical obstruction medically. So that's why I think a lot of times these medications just don't work well in clinical trials of patients with PSC, and it's such a heterogeneity of patient populations with PSC that the drugs may work better in people with small duct PSC. There's a potential that they might work better in that group of patients. I think in the patients with significant stricturing intra and extrahepatic duct, it's probably unlikely. I think these drugs are going to be very efficacious and down the road. But obviously, time will tell, and hopefully, some better options for patients in the future.
Hopefully. All right. So in PSC, is there any such thing as remission from the disease?
I mean, there are some people who do well over many years. I mean, I've had some patients who have had PSC that's been sort of slowly progressive and then it stays stable for many years. I think that's sort of a small number of patients who do go into remission. I think the majority of patients do have a slowly progressive disease over many years. There are some patients who, yes, do go into remission. You always wonder, did you have the correct diagnosis in the first place? Maybe there was something else that was causing, maybe they had a secondary sclerosing cholangitis for some reason, and maybe those patients, there may be some bias towards those patients go into remission, may not be classic PSC. Plus there's a huge heterogeneity. I think the small duct PSC, I think a lot of those patients will be much more stable for many, many years compared to the people with significant disease. So yes, I think some patients go into remission, but I think that's the minority of the patients.
All right. Next question is, will someone with PSC need a liver transplant?
So not everyone with PSC is going to need a liver transplant. I mean, some patients, unfortunately, will develop complications of PSC, such as cholangiocarcinoma, and some of those patients will not be candidates for liver transplant. I mean, some centers are doing, obviously, liver transplantation for certain types of cholangiocarcinoma. Unfortunately, the majority of these patients with cholangiocarcinoma will not be candidates for transplant because it's frequently diagnosed at a later stage, and transplant is not an option. Certainly patients with small duct or intrahepatic PSC are probably less likely to require liver transplantation down the road. But I think a majority of patients, if they're eligible candidates and when they develop the PSC, if they have progression of disease, may ultimately require liver transplantation.
Which patients then ultimately, or which features lead you to refer someone for a liver transplant with PSC?
I mean, certainly if we see progression of their liver disease, so if we know someone has cirrhosis, complications of cirrhosis, then obviously that would be an indication to send people, for liver transplantation. If people develop jaundice, weight loss without obvious evidence of cholangiocarcinoma that we can tell, although sometimes that may be difficult to diagnosis. Some patients with, difficult pruritus to control is obviously an indication for some patients. So I think they would be the main reasons we would send people, just really for complications of cirrhosis or just progression of disease, whether it's because of the cirrhosis or because it's of a biliary stricture that's not able to be managed, and always because of the concern of cholangiocarcinoma. But it's often difficult to make that diagnosis. That's, I think, where most of us run into problems. So I think early referral to a transplant center really is the key. I mean, so they can evaluate them. So I think once you notice that for patients as their bilirubin starts going up, then I think that's really the time just to start, getting these patients seen at a transplant center so they can get specialized imaging, specialized ERCP and intervention if they need it, and certainly, proper evaluation for cholangiocarcinoma.
Yeah. And obviously these patients, sometimes they're, given it's a bile duct disease, their bile ducts become worse before their liver does. And in liver transplant, obviously we transplant commonly using the MELD score, and these patients sometimes don't always mount the MELD score or have cirrhosis at that time. And so early referrals are important so that if someone needs, something like a living donor or other things like that, they can be involved early in the process so that these patients can get the transplant when they need it.
Yeah, I think the key is, with development of a living donor, that's sort of opened up a huge new avenue for these types of patients, that you can transplant them earlier in the disease course, hopefully before they run into complications. You don't really have that option, like you said. In other patients, you're just relying on their MELD score, and they can't get a transplant until their MELD score gets to a certain number.
Yeah. And before we talked about can we interrupt the disease process, and is there any cure for PSC? Does it come back after transplant?
I mean, certainly in some patients, yes, PSC does come back after transplant. I mean, that's one of the issues that can happen with any sort of immune-related disease, affecting the liver. Obviously, the progression of PSC prior to transplant may have some effect on maybe some of its recurrence post-transplant. Some of the medications we use during transplant may help, prevent PSC, or may help the inflammatory bowel disease if that's present, post-transplant. But yes, there are some patients who will develop, recurrent PSC post-transplant, although our experience has been not typically as severe, in a lot of patients who do develop it, but there are a small subset of patients who do develop pretty progressive, PSC post-transplant. So whether that's related to recurrent PSC or ischemia-related disease, it's sometimes hard to differentiate between these two entities.
At what time course would you expect someone to develop PSC after transplant?
So most patients that we see would develop it sometimes in the first couple of years after transplant. There are some patients we see, many years later after transplant who develop this. So that's always raised the issue of whether this is recurrent PSC. I think when it happens sooner after transplant, it may be recurrent PSC or maybe some component of ischemia, those two things related. But a lot of these patients, you do see sometimes many years post-transplant with development of recurrent PSC.
Are there any trials currently for PSC, and how can someone find more information about them?
Well, I think you can find a lot of good information, obviously, at the American Liver Foundation. So I think they always have a very good website, looking at trials that are upcoming in PSC. Certain academic centers, if you look at their individual websites, they're always a good source of, resource. And then obviously, if your primary care doctors may not have access, but certainly liver specialists in your area or transplant centers typically have ongoing trials in some centers with PSC.
Well, hopefully if people keep enrolling in these and people keep investigating this, as we've alluded to, I guess, multiple times, both of us, that more information and more study in these populations is really what's needed. A lot of what we've talked about today is that we're learning more over time, but we don't have great tools yet. And so I think continuing to do clinical trials and large research consortiums that can, get more people involved could hopefully help us understand the natural history, how to interrupt it, its associations with, inflammatory bowel disease and other conditions, and what treatments we have for it. So I know there's a lot of people looking and spending time and money, and the American Liver Foundation obviously is supporting this. And obviously over time, hopefully we can get some answers.
Yeah, no, I think it's an exciting time, in cholestatic liver disease, with PBC or PSC, a lot of different treatments becoming available and a lot more research going on over the last 5-10 years than there had been for many years. These diseases, I think, have been quite static for a number of years. I think there's definitely been an acceleration and interest in, managing these diseases. So hopefully, as you said, in the future, we'll have better options for patients and better treatments.
The next question. Why do people with PSC need to be screened for cholangiocarcinoma?
So one of the main complications of PSC is the development of progressive liver disease or cirrhosis and complications of cirrhosis. The other complication that can happen in patients is the development of bile duct cancer or cholangiocarcinoma. So it is important in patients with PSC to get regular screenings done for cholangiocarcinoma through a combination of blood tests and imaging tests.
Dr. O'Riordan, when you're talking to patients, do you have any specific PSC patients, do you have any specific recommendations regarding COVID?
Well, I think on these patients in general, because they do have sort of a depressed immune response and immune system, I think it's important to get vaccinated for all diseases, that could affect them, such as influenza and pneumovax vaccination. Obviously, with the recent pandemic, we will recommend COVID vaccination for patients both pre and post-transplant if they've not already been vaccinated against COVID.
That is all the questions we have for today. Thank you, Dr. O'Riordan. It's been such an informative program. For additional information on your liver health, please visit liverfoundation.org, and thank you for joining us today.